Hello everyone. Nowadays, everywhere the talk is about incretins, GLP-1 receptor agonist. You might have heard about semaglutide with various names like ozempic, wegovy, etc. We can see it is being discussed at various scientific programs, CMEs, numerous experienced doctors and some health influencers as well. So, I thought before getting influenced by all of these, we will make the basics of these particular drugs stronger. So, we'll understand this particular molecule today. We know that it is a clinical breakdown in recent times with the new class of molecules. So, there is a typical shift in the treatment paradigm you can clearly see. Previously, it was mainly upon the glucose-centric model, controlling blood glucose levels. Now, it is more towards cardiometabolic protection or safety, which we have discussed previously in one of our videos about diabetes updates. So in this particular video, we are going to discuss the mechanism of action of this particular drug, the efficacy and some cardiovascular outcome trials, dosing, adverse effects, the role of diet and exercise, which is very much important when it comes to patient guide. So we'll discuss in detail. Then what are the effects of discontinuation, which is commonly asked doubts in various programs. Coming to the first one, that is mechanism of action of this class of drug, we know that these are all the synthetic analogues of our native hormone, that is nothing but GLP-1, and it will, that is this class of drugs will resist degradation by DPP-4 enzyme, which normally degrades fastly the native hormone GLP-1. With this action, they will have extended half-life from minutes to days. In the sense, our natural hormone will have its half-life in minutes, so it will be degraded very early, but these analogues will have extended half-life. So how does they act? When it comes to pancreas, there will be glucose-dependent insulin secretion. So it will stimulate beta cells of pancreas to synthesize insulin, especially postprandial, and it will also suppress glucagon production. When it comes to gastrointestinal effect, we know that it will slow down gastric emptying. Thereby, again, it will prevent postprandial spikes. And in brain, it is being claimed that it will increase satiety so that the individual will feel full early, and it will decrease cravings. So automatically, the intake or the overall calorie intake will be reduced. And coming to cardiovascular benefits or mechanisms, it is being claimed that it has multiple actions, important being endothelial health promotion, so that overall initiation of the cardiovascular events will be prevented. So these are some mechanism of action. Coming to the efficacy in mainly two groups, one is diabetics and one more is obesity. In diabetes, it will reduce HbA1c by 1 to 2% with very low risk of hypoglycemia, because the mechanism, as we just now discussed, it is mainly based on the glucose dependency. And these effects are shown in some clinical trials named SUSTAIN trial, mainly with semaglutide, and SURPASS trial with Tirzepatide. When it comes to efficacy in obesity, it is seen that there will be up to 15 to 20% of weight loss, as shown by STEP trial using semaglutide and SURMOUNT trial using Tirzepatide. So all these trial names are also important. You can check out the entire details of these trials to know more information. Coming to cardiovascular safety and outcome trials, it has been seen that semaglutide will reduce major adverse cardiovascular events like stroke or MI, etc. by up to 20%, even if the person is non-diabetic, obese or overweight, which has been shown in SUSTAIN 6 trial and SELECT trial. Coming to liraglutide, there has been significant cardiovascular benefits as shown by LEADER trial. Then coming to Tirzepatide, it has shown superior cardiovascular protection in SURPASS trial. So these are some landmark clinical trials with these particular class of drugs. Coming to the dosing strategy. So what we have to follow here is, we should start low and we should go slow. So ideally start with the lowest possible dose and we should keep on increasing the dose very slowly. For example, The commonest one being semaglutide. Initiation should be 0.25 mg every weekly, one injection should be given for 4 weeks. So this will complete the first month. Then we have to follow escalation. So we have to start giving 0.5 mg every week for the next 4 weeks. Then comes the titration. We have to keep on increasing the dose. For example, 1 mg every week, 1.7 mg every week, 2.4 mg every week until maintenance dose is reached. What is maintenance dose? Dose level where the expected weight loss has happened. That will be the maintenance dose for that particular individual. So we have to maintain that particular dose. There is a trick here. That is, if patient experience severe nausea, which is very common with this class of drugs at any point of time during all these therapy, we should not escalate further. We have to maintain the same dose for another 4 weeks. That is, one more month we have to take time. Otherwise, if required, we have to reduce the dose slightly so that the individual will be feeling better by avoiding severe nausea. This point is very, very important during the titration of the dose. Then comes one more doubt, that is, what about the concurrent medications of diabetes? See, if the patient is using metformin or SGLT2 inhibitors, they have complementary actions in diabetes management. So it is safe to continue along with GLP-1 drugs. Whereas if the individual is on sulfonylureas or insulin, there will be high risk of hypoglycemia. So what we have to do? We have to reduce the dosage. For example, if the individual is on sulfonylureas, reduce the dose to 50%. If the individual is on basal insulin, reduce by 10 to 20%. This one we have to follow whenever we are starting with GLP-1. What about the one who are on DPP-4 inhibitors? Just discontinue this class of drug because both will have the similar mechanism of action with no added extra benefits. What about the adverse effects? We know that commonly patients will experience nausea, vomiting, diarrhea and constipation. These are very common, but they are transient. It means the patient will get adjusted to the class of drugs slowly. When it comes to gallbladder effects, sudden weight loss might lead to development of cholelithiasis. And there are some claims about development of pancreatitis, but it is just theoretical. Coming to thyroid health, this class of drug might stimulate the C cells, leading to development of medullary thyroid carcinoma. So we have to be careful if there is family history of thyroid malignancies. So these are the effects which are commonly discussed, but these are all rare except the first one. The important one to remember are there might be deficiency of micronutrients such as vitamin D, B12, iron, zinc. So it is very important to follow up with the panel of these micronutrients at a frequent intervals, at least yearly once, if the individual is on GLP-1 receptors. Then comes the role of diet and exercise. Remember, these are not the magic pills. Lifestyle still matters. There might be risk of sarcopenia because as there will be rapid weight loss, it is a common physiology of the body to lose fat as well as muscle mass. So our aim should be to reduce fat, not the muscle mass. So it is important to advise the individuals to undergo resistance training every week. At least 2 to 3 times weekly, they have to do weightlifting exercises. And to prevent muscle loss, it is important to take protein properly. So we have to advise for high protein intake, that is at least 1.2 to 1.5 gram per kg body weight. It is also important to guide about the hydration. Minimum 2 to 3 liter per day should be advised because slower gastric emptying by this class of drugs can reduce thirst cues. So the patient might not be feeling thirsty and they might be having reduced intake of water, leading to dehydration, sometimes even acute kidney injuries. Then comes one more doubt. Since many years we have so many drugs in obesity management, why only GLP-1 receptor agonists, these newer molecules, are emphasized so much, not other class of drugs. For example, orlistat, topiramate, phentermine, etc. Remember, with GLP-1 receptor agonists, we can see a moderate degree of weight loss. As mentioned in the beginning, 15 to 20% of the weight loss is seen. Whereas with older drugs, hardly up to 5% of the weight loss was seen. Then these drugs have cardiovascular protection, renal protection, and important thing is they will modify the disease, not just managing the symptom. That's why this class of drugs are discussed everywhere. Now, which one to choose? There will be a confusion among semaglutide, tirzepatide, or should we go with bariatric surgery? So for this, we have to follow some of the considerations. For example, if your target weight loss is about 15%, we can go ahead with semaglutide. If it is 20 to 22%, we can choose tirzepatide. If it is quite higher, for example 25 to 35% of weight loss is expected, go ahead with bariatric surgery. Type 2 diabetes remission rates will be higher with semaglutide, that is very good control itself. When it comes to tirzepatide, it is quite higher, very high we can say. Bariatric surgery, we can say the highest control we can see. Coming to cost, as of now, in Indian perspective, we can say cost is higher for all of these. But when it comes to bariatric surgery, it will be a one-time upfront cost, whereas these injections are weekly injections, so there will be recurrent expenditures over the medications. Coming to invasiveness, we know that these are weekly injections, whereas this bariatric surgery is a one-time major surgery. Whom this class of drugs will be ideal for? Remember, if the BMI is more than 27 with major comorbidities, and we are expecting 50% up to 15% of the weight loss will help that particular individual, we can go ahead with semaglutide. Suppose the BMI is even higher, for example more than 30, or you have already tried semaglutide but which has failed. So in that case, we can go ahead with tirzepatide. So we can say failed semaglutide individuals, we can choose this one. Whereas if the BMI is fitting into morbid obesity, like about 35 to 40 with some major metabolic diseases, if the individual is having, we need a greater degree of weight loss. In that case, we have to choose bariatric surgery. So these are some points to consider when choosing among these three options. Important point is the patient guide for better compliance. We can see that once we start with the medications, there might be some adverse effects which will be inhibiting the individual from taking these medications, or in opposite cases, there might be a rapid improvement, that is significant weight loss, which will make the person to feel that we can stop the medication now because I have achieved the goal. So how to maintain the compliance? We have to advise the patients that it is not a diet pill. Instead, what we are giving is nothing but your own body's hormone, GLP-1. And remember, we will start low dose and we will go slow because your body will take time to adopt. And if there are any side effects, they will fade away within few weeks. So no need to worry about the side effects much. And some other advices are like eat small portions so that fullness of the stomach with regurgitation should be prevented. Hydrate very well, as mentioned earlier, 2 to 3 liters minimum we have to advise. Avoid spicy foods, and if you are facing constipation, use fiber rich food sources. And remember, we are aiming for fat loss, not the muscle loss. So it is important to lift weights and have adequate protein under the guidance of nutritional expert or the doctors. And remember to rotate the injection sites so that we can avoid severe nausea. And try to choose on the Fridays, because as the peak action within 2 to 3 days, usually people will be having a tendency to have more cravings during weekends. So we can avoid that one. It is not a rule, but we can utilize this particular day for the injection. And also remember, avoid consumption of alcohol when we are using this particular class of drugs to avoid the risk of severe hypoglycemias. So we can say Friday and dry day both are important when we are using this class of drug. Then comes one more important doubt, that is what happens if an individual discontinues the treatment. We can see there will be a metabolic whiplash, that is severe rebound changes are seen in patients who are discontinuing the medication. For example, when it comes to cardiovascular health, there will be up to 22% rise in major adverse cardiovascular events within a year, and it is being published in BMJ journal recently, that is in March 2026. What about the weight? It has been seen that about 2/3 of the lost weight will be regained within a year, which is shown in Step 1 extension trial and Surmount 4 trial. What about the metabolic benefits which the individual has gained during the treatment? See, HbA1c will be back to pre-treatment levels within months, and some other metabolic parameters like blood pressure, LDL cholesterol will reset to the baseline within months. And because of the regain of the lost weight and all these reset in the metabolic parameters, obviously the individual will have psychological impact of failure. If it is so, is it a lifelong therapy? Remember, this medicine does not fix the biology, it manages the problem, that's it. As we know, while treating hypertension, it is quite a lifelong therapy. Similarly, obesity treatment as well is a long-term therapy. But recently, it is being tried for tapering or some other alternatives to avoid this class of drug as a lifelong therapy. So what they have tried is like some strategies such as spaced out dosing. That is, once the weight plateau is achieved, instead of every 7 days, we can advise to go ahead with every 10 days injections or every 14 days injections once, so that it is nothing but a kind of tapering in the dosage. This one they are trying, but not yet published completely. Otherwise, few people are preferring bridge therapy, using other anti-obesity medications once the proper weight loss is achieved, for example topiramate or bupropion. Again, these are all the trial and error methods just to avoid inhibitory mindsets of the patients for lifelong therapy and to reduce the cost in some cases. Hope you have understood all the concepts related to this class of molecule. Thank you so much for listening till the end. Overall, the point is, these are all the new class of drugs, so we have to know the concepts behind these drugs. Then we have to start using in the patients. Over the time, we will be able to see the results. So, as mentioned, पहले इस्तेमाल करो, फिर विश्वास करो. Share this video if you find it useful, and please subscribe to the channel for more such informative videos. Thank you.